Should we start, ma'am?
Yeah, I'm ready.
Okay. Good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 13K, which is Pathology of the Head and Neck. We are streaming live from RCC Thiruvananthapuram via Kolkata. And a very interesting topic, Nasopharyngeal Carcinoma, a systematic approach to diagnostic issues. And to talk on that, we have Dr. Anila K R. She is an expert in head and neck pathology. She is an MBBS, DCP, DNB in pathology from GMC Thiruvananthapuram, Kerala. Presently, she is an associate professor in the Department of Pathology at the Regional Cancer Center, Thiruvananthapuram, with more than 50 international and national publications. Her area of interest is surgical pathology, head and neck, endocrine, and cytopathology. She was awarded the fellowship by the Union for International Cancer Control in the 2018. She's undergone training in head and neck and cancer pathology at the famous Mayo Clinic, USA in 2018. Before I ask Madam to start, let me request all of you to please keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. Anila ma'am, please share your screen and let's start. Perfectly fine, ma'am. Please start.
Yeah. So at the outset, let me thank Dr. Nadeem and Nilam Pathology for once again inviting me to this platform. So today's topic is Nasopharyngeal Carcinoma, a systematic approach to diagnostic issues. So I have planned this lecture in such a way that in the first half, we'll be dealing with the Nasopharyngeal Carcinoma. We'll briefly go through that. And at the end of the presentation, I have kept 3 cases so to address some of the diagnostic issues that come across in this nasopharyngeal area. So with that, nasopharynx is the superior portion of the pharynx. So it is actually a small anatomical area which is situated behind the nasal cavity and above the soft palate. And the contents of the nasopharynx include nasopharyngeal tonsils or adenoids and the orifices of the eustachian tubes, which actually open to the lateral wall of the nasopharynx, and the fossa of Rosenmuller, which we are all familiar as it is the common site of origin of nasopharyngeal carcinoma. So this is a beautiful schematic representation which I have got from the ICCR site, and here this is our area of interest today. You can see that it is situated, this nasopharynx is situated posterior to the nasal cavity, and it is continuous below with the oropharynx. So it is situated above the level of the soft palate and behind the nasal cavity, and containing the adenoid, the opening of the eustachian tube on the lateral wall, and the fossa of Rosenmuller. So by definition, the WHO defines nasopharyngeal carcinoma as a carcinoma arising in the nasopharyngeal mucosa that shows light microscopic or ultrastructural evidence of squamous differentiation. So this squamous differentiation is important because other types of carcinomas can also rarely arise in the nasopharynx, but when we write down the diagnosis as nasopharyngeal carcinoma, we are implying that it is a squamous cell carcinoma. All other carcinomas can't be diagnosed as a nasopharyngeal carcinoma. You can't use that terminology. So, nasopharyngeal carcinoma can be squamous cell carcinoma, of course, and they can be non-keratinizing squamous cell carcinoma, which is the most common, or the classical nasopharyngeal carcinoma is the non-keratinizing squamous cell carcinoma. Also, you can get keratinizing squamous cell carcinoma and basaloid squamous cell carcinoma. So that is rare. The most common being non-keratinizing squamous cell carcinoma. So these three you can label it as nasopharyngeal carcinoma. But rarely you can get other types of carcinoma in the nasopharynx, mainly the nasopharyngeal papillary adenocarcinoma, which is quite rare, and also salivary gland type carcinomas like adenoid cystic carcinomas are known to occur in the nasopharynx. So these two entities cannot be, the last two cannot be called as nasopharyngeal carcinoma. Only the squamous cell carcinomas are come under the terminology, the broad terminology of nasopharyngeal carcinoma. So as we all know, etiology-wise, there are specific etiological factors proposed for the pathogenesis of nasopharyngeal carcinoma. One such is race, second is environmental factors, genetics, and we all know that nasopharyngeal carcinoma is one of the carcinomas wherein Epstein-Barr virus is implicated in the pathogenesis. So race-wise, you have a pocket in the Southeast Asia, mainly in the Chinese, in the Hong Kong area, and also in North Africa. These people have an increased incidence of nasopharyngeal carcinoma. So that is mainly because of their dietary contents, that is the nitrosamines which are present in the fish, the salted fish that they introduce even in the weaning period, that serves as a carcinogen, activates the Epstein-Barr virus, and that is why it is we have a pocket there in Southeast Asia and also in North Africa. So, and other factors which are implicated in the pathogenesis are chemical fumes, formaldehyde, radiation, and many such things. Genetics, the association with human leukocyte antigen has also been proposed as an etiological factor. Then, of course, the Epstein-Barr virus, we all know that it is involved in the pathogenesis of nasopharyngeal carcinoma, but mostly in non-keratinizing squamous cell carcinoma of the nasopharynx. It is not so much that much associated with the keratinizing carcinomas. So the clinical presentation, if we go through it, you have a bimodal pattern. That is, you can get in children, that is in adolescent age group as well as in the adults. So in adults, it is between the age group of 40 to 60 years that we come across nasopharyngeal carcinoma. And literature says that there is definitely a male predominance in the ratio, with the ratio of 3:1. And most of them present with non-specific symptoms related to the mass in the nasopharynx. Like because of the mass in the nasopharynx, they can present with nasal block, epistaxis, postnasal drip, which is blood tinged, and so on. And also when we went through the anatomy, we found that there is the opening of the eustachian tube onto the lateral wall. So that some patients can present with tinnitus, otitis media, and so on. And symptoms always depend on how much the tumor is advanced. The higher stage tumors, if they have and involved, the stage 4 tumors, particularly involvement of cranial nerves and all, then the symptoms will be diplopia and so on, facial pain and so on. And also, the nasopharyngeal carcinomas, they are well known to present as carcinoma of unknown primary or CAP. And when they do so, the levels of lymph nodes, one helpful thing about head and neck cancers is that the lymphatic drainage is pretty predictable, so that if we know which level of node is involved, we can usually suggest the primary. So in head and neck cancers, it is mostly your jugular nodes that are involved, the level 2, 3 and all. So the common lymph node to be involved in nasopharynx is also the jugulodigastric, the level 2 node. But I have highlighted this posterior cervical in red just to get your attention that among the head and neck cancers, if you're suspecting a head and neck primary and you're getting a posterior cervical level 5 node, then it is likely to be a nasopharyngeal primary. So outside the head and neck, this is not relevant because other sites like thyroid, breast, lung, all can go to your level 5. But if you are suspecting a head and neck cancer, then this posterior cervical is important because nasopharynx is a site for metastasizing to the level 5 posterior cervical node. So now let us go on to the morphology of this nasopharyngeal carcinoma. So first I have taken up this non-keratinizing squamous cell carcinoma, which is the most common and classical nasopharyngeal carcinoma. So these come in sheets, syncytial appearing, very characteristic, islands, trabeculæ. And these are intimately associated with lymphocytes, plasma cells, and sometimes even eosinophils. And this intimate association has earlier given the name of lymphoepithelioma to this group of cancers. So if you take the WHO previous editions and all, there are a lot of terminologies for this group of cancers. So the lymphoepithelioma is actually a misnomer because the lymphocytes are not part of the tumor and it is not an epithelioma, it is a cancer. So that terminologies are all now obsolete and WHO does not advocate the use of such terminologies for this cancer, and that is why it has come with specific names. So there's no confusion now. You can call it a squamous cell carcinoma, keratinizing, non-keratinizing or basaloid. Okay, then the cells are large tumor cells. Nuclear chromatin is vesicular and the nuclei is often prominent. I'm highlighting these histopathological features because many a times, because of these characteristic features, a lot of differentials come. When we look under the microscope, if these syncytial appearing cells are broken up by these infiltrating lymphocytes into single cells, just imagine you can have a whole lot of differentials other than a carcinoma coming into your diagnosis. And usually these cells have high NC ratio with amphiphilic cytoplasm. So this is from one of our cases of nasopharyngeal carcinoma, nasopharyngeal biopsy, showing these tumor islands which are densely infiltrated by lymphocytes. So you can see that if these are broken up into small cells, sometimes it is even difficult to appreciate these large epithelial cells amidst this florid lymphocyte infiltrate. And that is actually one of the challenges in the diagnosis of nasopharyngeal carcinoma. So this is a higher power view of the same, showing the characteristic morphology. In almost each and every cell, you can see this prominent nucleoli. So unlike a keratinizing squamous cell carcinoma, the desmoplastic stroma is uncommon in a non-keratinizing carcinoma. And sometimes, if you're lucky, you will get a more transitional type of ribbons of epithelium so that you don't have difficulty in picking up the carcinoma. So previously we used other terminologies that were used for these group were undifferentiated carcinoma, differentiated carcinoma and so on. So undifferentiated refers to both these are actually implies the patterns that you see under the microscope. They are just histopathological patterns. And even in the same cancer, you can see both these patterns together. So undifferentiated is all those syncytium and islands of tumor cells which are infiltrated with lymphocytes. Differentiated refers to the ribbons or of the tumor cells where you don't have much difficulty in identifying them as carcinoma, and sometimes they show some focal keratinization and intercellular bridges which are characteristic features of squamous cell carcinoma. And previously, these well-defined epithelial islands were termed as a Rigord pattern, and the individual cell pattern was called as Schminke pattern. Now, all these are not encouraged by the WHO simply because they don't have any clinical or prognostic significance. They just refer to some patterns. But from a pathologist's point of view, these patterns are important because it is usually the undifferentiated or single cells that we see which causes a lot of diagnostic difficulties because we may not even appreciate them to be carcinomas. So apart from that, there is no significance to these terminologies. Please don't use them in your diagnosis of nasopharyngeal carcinoma because it wrongly, if you use the terminology, this undifferentiated, sometimes your clinician may get worried. He may extrapolate it to be a poorly differentiated carcinoma when actually it is not so. It is just a pattern. So you should defer from using such terminologies and stick to the terminologies which are proposed by the WHO. So this is again a higher power view showing these single cells with admixed lymphocytes, and here some syncytial clustering. Definitely with this area you can identify that it is a carcinoma because of some degree of cohesiveness, but here and all you're just seeing single cells. So a basic panel that will help us is a pan-cytokeratin, which will definitely be strongly positive. And because they are squamous cell carcinomas, squamous markers like P40, P63 will be helpful. This picture I have borrowed from the pathology outlines because I wanted to put this in my talk. Just to simply highlight that this nasopharynx, often the biopsies from the nasopharynx, because the tissue is delicate and it is a difficult site to get a biopsies, and most or many of the times it will be crushed. So a crushed specimen, a crushed tissue with plenty of lymphocytic background, there is a high likelihood that we may miss a carcinoma within it. So to bring out the carcinoma cells, we definitely need to put a cytokeratin, and this characteristic meshwork pattern staining can be seen in such cases because what the cytokeratin highlights is just the wispy cytoplasm that is remaining in the tumor cells which are densely infiltrated by lymphocytes. So it's a very characteristic pattern. You may not always get, but if you see it, you mostly see it when you think that the biopsy is negative for malignancy, you put a cytokeratin and then suddenly this highlights this beautifully the atypical cells which are hidden within the lymphocytic background. So this helps. So this is one of our cases wherein we had done the P40 to highlight that the squamous nature of the cells. Now about the EBV, we know that Epstein-Barr virus is associated with nasopharyngeal cancer, and it is usually found in the non-keratinizing classical type of nasopharyngeal carcinoma. Currently, we have many tests to demonstrate the EBV, and in situ hybridization or polymerized chain reaction can be used. But at present, the most sensitive and specific test for diagnosing EBV is the EBER, in situ hybridization for EBER, which detects the EBV encoded small RNA. That is the most sensitive and specific test available. So do you need to do this EBER for diagnosis? Actually, not in each and every case, because if it is a classical case, you got your cytokeratin and squamous marker positive, then you don't have to actually do EBER for diagnosis. But it serves as a prognostic marker because EBV association carries a better prognosis. So if you want to prove the prognosis of a particular case, you can do that. But another scenario which is very useful for the use of EBER is when the case presents as a cup or carcinoma of unknown primary. and we don't know, and if we put an EBER and it turns positive, then it is almost very sure that it is a carcinoma of the primary could be the carcinoma in the nasopharynx. So that is one of the use of EBER. So this is one of our cases of cup wherein we had done a EBER, and this shows the nice nuclear labeling in almost each and every cell. It is nicely labeled. This nuclear brown labeling is the positivity. So EBV serology is also available, like serum IgA against viral capsid antigen and IgG IgA against early viral antigens are all available, and these can be actually used for follow-up. So you have a diagnosed case who has completed treatment, and then you are following up and you're suspecting a recurrence. Maybe you can look into the serology, and if the levels are raised, you can suspect a recurrence. And the test which is available but is not at all relevant is the latent membrane protein of EBV. That is not a reliable test. Now about keratinizing squamous cell carcinoma. This is not as common as the non-keratinizing, and this has altogether a different etiology. Like the rest of the head and neck cancer, smoking, alcoholism are the causes of this keratinizing squamous cell carcinoma. It can arise de novo or rarely secondary to radiation also. And generally, EBV is absent or low in keratinizing squamous cell carcinoma, and that is why it has a worse prognosis than the non-keratinizing. So, like other squamous cell carcinomas of the head and neck region, the keratinization is there, intercellular bridges are there, dysplasia is there, desmoplasia is there. Remember, all these features are absent in your non-keratinizing. So, this is a classical squamous cell carcinoma like elsewhere. Now, something about tumor grade. The keratinizing nasopharyngeal carcinoma is graded, applying all the criteria that you do for a routine squamous cell carcinoma of the head and neck region. But non-keratinizing nasopharyngeal carcinoma grading is not applicable, and it is not advisable to grade. Why so? In my previous talk on HPV also, I have said that in HPV associated oropharyngeal grading is not applicable. This is because even this nasopharyngeal carcinoma, it is non-keratinizing. So if we are to grade, we will be applying the criteria of a keratinization. So there is no keratinization, no intercellular bridges, so nothing to suggest a lower grade. So these invariably will fall into the criteria of poorly differentiated, which is not so because the EBV related non-keratinizing nasopharyngeal carcinoma are prognostically favorable. They do better than the keratinizing. So you don't, because of this lymphoepithelial non-keratinizing morphology, if we were to extrapolate the criteria of keratinizing nasopharyngeal into the non-keratinizing, we will end up wrongly grading them as poorly differentiated. So we do grade a non-keratinizing nasopharyngeal carcinoma. So treatment, these tumors are very sensitive to radiotherapy, and that is why as pathologists, we will be usually receiving only biopsy specimens. We won't be receiving radical surgery care specimens, so usually we won't be getting. And the non-keratinizing squamous cell carcinoma is sensitive and keratinizing is less sensitive. And in advanced diseases, they give chemotherapy also. If in some centers where both these therapies fail, they may go in for a surgery, but it is very rare. So what are the prognosticators? Prognosticators, mainly the first and foremost thing is the stage of the disease. So something has been modified in the staging of nasopharyngeal carcinoma. So later stages are previously, if the tumor, you know that from the anatomy that the nasopharynx is in close proximity to the nasal cavity, the oropharynx, the paranasal sinuses, and so forth. So previously, if the tumor extended to the nasal cavity or the oropharynx, it was taken as T2, but now it is not so. They are still stage T1 only. So like that, a stage 1 disease will be having a better prognosis, and because of the close proximity, the tumor can go on into your paranasal sinuses, even skull base, intracranial extension, involvement of cranial nerves, which all make it a stage 4 disease. So then that is a bad prognostic indicator. Then tumor volume. So if you have a bulky tumor, of course it will have a bad outcome. Then age more than 40 years, male sex, all these are associated with a bad prognosis. Okay, and about the non-keratinizing versus keratinizing and EBV association, I have told that the non-keratinizing and the EBV association is associated with a better prognosis. So nasopharyngeal papillary, I have just ended the talk on nasopharyngeal carcinoma, but I will just mention briefly because this is also nasopharyngeal carcinoma, but it is a papillary adenocarcinoma. Another synonym for that is thyroid-like low-grade nasopharyngeal papillary adenocarcinoma. It is very rare and it can affect any age, and it also presents with nasal non-specific symptoms because of that nasal mass. This is the architecture. As we can see, there are nice papillae and the nuclear features clearing and resembles the thyroid papillary carcinoma with secretions also you can see. And the TTF1 is positive in many cases, and that is the time we label it as a thyroid-like nasopharyngeal papillary adenocarcinoma. But thyroid globulin is negative in this cancer, and it has a very good prognosis. It's a low-grade tumor. And here the surgery is the line of management. Adjuvant therapy is majority of cases doesn't require adjuvant therapy, and this group of tumor is associated with very good prognosis. So the salivary-like carcinomas I'm not touching upon in this talk. So now we'll go to the cases that I have put up. So this was a 15-year-old boy who had presented with bilateral posterior cervical node enlargement. Initial clinical assessment did not reveal any primary, and clinically they were suspecting lymphoma. A 15-year-old child with bilateral posterior cervical node, and they did an excision biopsy. So this is the image from the slide, and you can see here the lymphoid follicle from the lymph node, but there is a whole lot of effacement of architecture with this all sheets and of cells. So this is from pathology point of view, we don't have a differential of a lymphoma in this case. You think of carcinoma only. So this is a classical picture of a non-keratinizing squamous cell carcinoma of the nasopharynx. So we proceeded with this is the higher power view, to show the prominent nucleoli and the intimate admixture of lymphocytes. So the cytokeratin, as expected, was diffuse, strongly positive, and the squamous marker P63 was also, you can do P63 or P40, and this is nuclear staining, strong positivity. So then, because this child had presented with no known primary, we proceeded with the EBER also, and this EBER shows this nice nuclear labeling. So with all this, the morphology was fitting. It was, as I mentioned in my lecture, it was a level 5 posterior cervical node. So in head and neck cancers, we will think of nasopharyngeal primary. This was not a difficult case because the morphology was also very characteristic of a classical nasopharyngeal carcinoma, and all the immunos and EBER also contributed to the diagnosis. So we worded it as metastatic, non-keratinizing squamous cell carcinoma, biopsy level 5 lymph node, compatible with metastasis from a nasopharyngeal primary. And they again went in and did a biopsy from the nasopharynx, and this time they were lucky and we got the nasopharyngeal primary in this biopsy. So a word about carcinoma of unknown primary site. So it implies that there is no primary tumor identified at initial presentation or after a thorough clinical workup. So if we are to apply this criteria, most of the carcinoma of unknown primary will won't be remaining as unknown primaries at the end of the clinical workup. Most of these cases will get sorted out and we will be able to identify the primary. So, and level 5, posterior cervical node. Among head and neck cancers, nasopharynx is a likely primary. But I don't want you to take the message like level 5 means nasopharynx. Nasopharyngeal carcinoma also, the most common site of metastasis to the cervical node is your level 2. But if you get a level 5 and you are suspecting a head and neck cancer, then nasopharynx is the likely primary. EBER is useful to confirm nasopharyngeal origin in cases presenting as cup. So this is a schematic representation which is very useful to know the possible primary site, because the lymphatic drainage of the head and neck area is pretty predictable, and by the level of nodes you can suggest which could be the primary. And you can see that level 2 nasopharynx and level 5 among the head and neck, it is the nasopharynx. The rest are thyroid, esophagus, lung and breast. So we'll go on to case 2. This was a case which recently came to us. It is a 63. He was a 63-year-old gentleman, and he had mass involving the nasal cavity and paranasal sinuses. The excision of which was done outside in June last year, and the outside diagnosis was non-keratinizing nasopharyngeal carcinoma, following which the patient was given radiation, and the radiation was completed in October 2020. So, but what happened was, within 7 months of completing treatment, the patient presented with large level 2 node, quite large, significant level 2 node. And neck dissection, he was referred to our center, and neck dissection was done at our center. So this was highly unlikely for a nasopharyngeal to relapse or to present with a metastasis within 7 months of completing treatment. So let us see. This was the node that we received, quite a large node with almost very completely, not completely, but almost replaced by this metastasis. This is the microscopy, and you can see that these are the syncytium of cells, and even single cells you can appreciate under the low bar, and this is the higher bar. So mostly these are single cells, and you can appreciate the prominent nucleoli. So they have abundant eosinophilic cytoplasm, eccentrically placed in most of the cases of the cells. The nucleus is eccentrically placed and with prominent nucleoli. So we definitely thought this was a bit of a wrapped out morphology, but of course at this stage also we thought that this is a carcinoma only. But whether it was nasopharyngeal carcinoma, we were not sure. This was the previous slides. Outside biopsy was also submitted for review. So the similar cells only with more of a nesting seen here with prominent nucleoli. So the panel, because we had this diagnosis of carcinoma only, the panel that we chose was cytokeratin, which was of course diffuse strong positivity. And then the P63. We had done both squamous markers, P63 and P40. Both were totally negative in our case, as well as in the outside blocks we had done this immuno. So P63 and P40 were negative, and even EBER was negative because the outside diagnosis was nasopharyngeal carcinoma. The EBER was also done, which was negative. Excuse me. And then we again went back to the morphology. By that time, we had this differential because it was the squamous markers were negative. We had the diagnosis of carcinoma only, and in spite of completing radiotherapy within 7 months, the patient had presented with node. We thought of another entity because the mass was predominantly in the paranasal sinuses and nose. We had a differential of a sinonasal undifferentiated carcinoma, which is INL1 deficient, because that subgroup of tumors are said to have a predominant rhabdoid morphology. So INI1 or SMARCB1 deficient. So this tumor cells are characteristically negative, very and the internal control, the lymphocytes have taken up nice positivity. So this was an INI1 deficient, SMARCB1 deficient sinonasal undifferentiated. and the T cell markers were also done, they were negative. And this was diagnosed as diffuse large B-cell lymphoma of the nasopharynx. So that is also a mimicker of nasopharyngeal. If you are not an expert in that area, you will have a difficulty. This case was actually not a difficult case, but I have put up this case to say that if you are not used to seeing, then you may mistake it as for a non-keratinizing nasopharyngeal carcinoma also. So it is better to put a cytokeratin and this with this. So then the differentials of non-keratinizing nasopharyngeal carcinomas, based on individual case, you have to frame your differentials. So if you're getting nice that ribbons of cells and all, you don't have a differential of any other differential, it is a carcinoma. You just have to substantiate that it is a squamous cell carcinoma and so forth. But what about when you get these lymphocytes breaking the syncytium into single cells? So these single cells, vesicular nucleus, prominent nucleoli, then your differential will be more like lymphoma. These can come into your differential, and you have to plan your immunopanel accordingly. And sometimes, as I have already mentioned, the background may not be lymphocytes alone. So the lymphocytes, eosinophils, even granulomas can be present. And when you see the individual cells, the large cells, as I have mentioned earlier, with vesicular nucleus, prominent nuclei, of course, they can mimic a Reed-Sternberg cell of your Hodgkin. So Hodgkin lymphoma, in such cases, Hodgkin lymphoma becomes a differential. So you have to approach the cases of nasopharyngeal biopsies, the malignancies of the nasopharynx, based on what you see under the slide, because the patterns can be different, and then make a histopathological differential and plan your panel accordingly. So sinonasal undifferentiated carcinoma, we have just seen one case. It can be a mimicker. Even Ewing sarcoma can be a mimicker. So IHC panel decisions will vary in each case based on histopathology. So with this, I think I have come to the end of my presentation. This nasopharynx is one such area where you can't just put a predetermined panel of IHC. You have to wait and proceed by and do. Like initially, you may have to put a cytokeratin and squamous, or cytokeratin and LCA, and then see how it turns out, and then work up your cases. So that's all, and thank you.
Hello, madam.
Yeah.
Very nice presentation. There are a lot of.
I'll be happy to
just read out the questions to you, ma'am.
Sure.
Yeah, please, one by one. First, it's Dr. Atrey Roy Chaudhary. He's from Calcutta. He says, is loss of intercellular bridges a reliable marker to differentiate between keratinizing nasopharyngeal carcinoma and non-keratinizing nasopharyngeal carcinoma?
That is a basic histology of squamous cell carcinoma that we teach our students, that if you see intercellular bridges, then it is an evidence of squamous differentiation. But in non-keratinizing, most of the times you don't see that. In keratinizing only you see these intercellular bridges. That is why I'm telling that in non-keratinizing, many a time you may be able to identify that it is a carcinoma, but you have to put a squamous marker and substantiate it. That is what I showcased, that one case of sinonasal undifferentiated. Right. Mere presence or absence of intercellular bridges doesn't make your point. If they are very prominent, then mostly keratinization also will be there, and then you don't have a diagnostic issue.
Right. Dr. Minesh Gandhi from Ahmedabad, he says, should we use NPC in situ in biopsy?
In what? I didn't get the question. In situ.
The question. In situ.
Is it in situ? No. No, you are not supposed to. No question of in situ in biopsy. No.
Yeah, Dr. Minesh Gandhi.
Because I'll tell you, because I want to explain it a bit more. Like in non-keratinizing nasopharyngeal carcinomas, you may not be able to even demonstrate. There's no dysplasia as such. In your keratinizing squamous cell carcinoma, you get dysplasias, and you can accordingly grade your dysplasia and call it in situ and invasive. In non-keratinizing, there is no such thing as in situ. You just have to write it is a non-keratinizing squamous cell.
Right, ma'am. Now, Dr. Minesh Gandhi has another question. He says, please share your experience, ma'am. Globules in nasopharyngeal biopsy, how much amyloid globules is reliable to predict diagnosis of nasopharyngeal carcinoma in tiny biopsies?
Yeah, in fact, in my experience, I have not come across this amyloid. Though literature and WHO tells about this amyloid globules, in my experience, I have not come across any case of amyloid globule, but in some cases, we do come across that mucinous material, so that we may mistake it for a adenocarcinoma. So that is there, but amyloid globule, though the WHO tells that amyloid globules can be seen, and but they are also not like in not so many a case. It can be sometimes present, that is what they tell. But in my experience, I have not come across this amyloid globule in any of our cases.
Right. Now, there is another question which is very interesting. I mean, in fact, this is very common, which all of us face is how to diagnose residual nasopharyngeal carcinoma tumors after radiation therapy. How to say that this is radiational, if ATR or it is a residual tumor.
Yeah, I got the question. So my take point on that is that usually our clinicians don't do a biopsy post-radiation. They assess the patient by the MRI, by radiological means. So if at all you are planning to do a biopsy post-radiation, because there will be radiation changes for at least 6 to 12 weeks, or even in some cases it will be more than that, it is difficult. And routinely in our center, at least, they don't do a histopathological confirmation to know whether the patient has responded to treatment. They do it by radiological assessment, radiological and clinical assessment. Radiological and clinical assessment is the way they go about. But of course, post-radiation changes. If you are getting a biopsy, there will definitely be post-radiation changes, and you have to take a call on that. It is going to be difficult.
Yeah, it's going to be difficult. That's absolutely right. It's going to be really difficult.
Yeah.
Right. Just wait for a minute, ma'am. Let's see if there are any other questions on the YouTube. We're just trying to lock that up. Yeah, there are no questions on the YouTube. Wonderful presentation, ma'am. You are a real expert in head and neck. We would like to invite you for a lecture on thyroid, NIF-TP, and other follicular pattern.
Yeah, sure. Why not? Why not?
Sometime,
it will be my pleasure.
Maybe a month or so later, I'll get in touch with you, ma'am. Thank you so much, ma'am, for such a wonderful, excellent presentation. Absolutely clear. Nasopharyngeal.
Thank you. Thank you. Thank you for the feedback. Thank you.
Please share your PDF so that we can pass it on to
the sure. I will do that.
Thank you so much. Good night. Take care. Bye.
Thank you.
Bye.